All right, welcome back to the session. This is the third talk in this session now, and this one is by Professor Hania Zajewska. We've been talking in multiple different sessions together, and we're a great tag team. We're talking about the basic science of oligosaccharides, and she's giving the broader overview of what these oligosaccharides can do based on the intervention studies we've seen so far. Dr. Zajewska is a professor and chair of the Department of Pediatrics at the Medical University of Warsaw in Poland, and until June 2019, she served the Journal of Pediatric America, also served as the secretary of the Asperger Committee on Nutrition. Most recently, in fact, January 2019, before the pandemic, feels forever, she joined the board of directors of the International Scientific Association for Probiotics and Prebiotics. And she has very broad interest in pediatric nutrition, but her research focuses on the effects of early dietary interventions on later outcomes, gut microbiota modifications with probiotics, prebiotics, and then also in context of diarrheal diseases. She has been a very active member in several European Union funded research projects, where she is an enthusiastic advocate for the practice of evidence-based medicine. She has co-authored more than 300 different publications, and today we'll be talking about selected human milk oligosaccharides as they're added to infant formulas for term infants. Welcome, Dr. Zajewska.
Hello and welcome to today's session on human milk oligosaccharides added to term infant formula, or more precisely, structures identical to human milk oligosaccharides added to term infant formulas. I will comment on it later on during my presentation. My name is Hania Zajewska. I'm the chair of the Department of Pediatrics at the Medical University of Warsaw, Poland. Human milk oligosaccharides, known for years, but discovered again. And you may ask yourself, what is behind current interest in HMO? Well, there are many factors, but I think that three are really important. First, advances in analysis of HMO, which allow much better to analyze HMOs than previously. Second, it's a progress in biotechnology, which nowadays allows to produce at least some HMOs to be added to infant formulas. And last but not least, two important organizations, EFSA, European Food Safety Authority, and FDA, Food and Drug Administration, independently confirmed the safety of 2-FL, 2-fucosylactose, and LLNT, lacto-N-notetraose, when added alone or in combination to infant, follow-on, and young child formula. So what I would like to discuss in my presentation, I will talk about some basic facts about HMO and health-related effects of HMO present in breast milk. I will talk about structures identical to HMO in breast milk added to infant formulas. Finally, I will talk about challenges in conducting infant nutritional studies. Let me start with the first topic, just to remind you some basic fact about HMO. The third largest solid components following lactose and fat. There are at least 150, probably 200, maybe even more structurally different HMOs. They have very specific branching and linkages, which are extremely important for their function. On this slide, I summarize major HMOs in human milk. They are fucosylated with a fucose added in this basic structure added to lactose, sialylated with a sialic acid added, on non-fucosylated neutral HMOs. The most abundant HMOs in 80% of mother's milks, namely that of secretor donors, is 2-fucosylactose, 2-FL. You will hear a lot about these human milk oligosaccharides during my presentation. HMOs have no nutritional value for the infant. Still, they have a number of functions, which I will not go into the detail. They support the infant's immune system. Examples just include prebiotic bag, antimicrobial, antiviral effects, which are covered in other presentations. What I would like to discuss in more detail are human cohort studies, which looked at specific HMOs, pooled HMOs, but especially specific HMOs in breast milk and health outcomes, which are listed on this slide. And let me go in more detail into specific HMOs and reduction of infection. And one of those infections is diarrhea caused by Campylobacter jejuni. There is a famous study, prospective cohort study from Mexico, published already some time ago in 93 mothers and infant fur, which have followed from birth to 2 years of life. And what has been nicely shown that if the mothers have high levels of fucosylated HMOs in their breast milk, that especially 2FL, 2-fucosylactose, it was associated with a lower risk of Campylobacter diarrhea and with severe diarrhea. So this is an important finding showing that specific HMOs play a role in protection against infant diarrhea. It's not only about bacterial pathogens, or also viral infections, beautifully summarized in this review article. And there are a number of proposed mechanisms of action how HMOs can prevent viral adhesion. So for any infection caused by viruses, what is needed is the attachment of virus to the glycan receptor on the surface of the epithelial cells. And the structure of this viral receptor is very similar to the structure of oligosaccharides, such as 2-fucosylactose. And if this HMO is present, it can adhere to the receptor on the surface of the virus and can prevent the attachment of this virus to the receptor on the surface of the epithelial cell. So they serve as a decoy receptors, and therefore they prevent this initiation of the viral infection. And last but not least, specific HMO indirectly elicit changes in the receptor binding, again protecting against viral infection. This has been shown in preclinical studies, but also in clinical studies when it comes to viruses such as influenza, rotavirus, respiratory syncytial virus, human immunodeficiency virus, norovirus. All of the viruses have no protection with 2-fucosylactose. Does it matter for future? Yes. It's one of the way of thinking is that we can think about HMO-based antivirals. Another group of studies, cohort observational studies, relates to HMOs and allergies. And again, you can see that specific HMOs have been linked with reduced risk of allergies. The data are not consistent, however, some of them are showing this positive effect. And I call your attention to this study, which shows that high levels of 2-fucosylactose potentially reduces the risk of IgE allergy in C-section-born infants at high risk for allergy. And there are many of those human cohort studies linking specific HMOs in breast milk and health outcomes, not only infections, not only in allergy, but also in sepsis, necrotizing enterocolitis, growth and body composition, and neurodevelopment and cognition. All of these studies are showing association, and association studies do not prove causality. However, they are very important as first step to intervention strategies. So my summary number one for this part of my presentation is breast is best, for many reasons, but one of them are HMOs, which provide at least 150 to 200 reasons to breastfeed. However, not all infants can or will be breastfed, and if not, they deserve the best we have got to give them. And this brings me to the second part of my presentations on structures identical to HMO in breast milk added to infant formulas. So let me start with a terminology. Well, when it comes to these HMOs, which are added to infant formulas, there are various terms used, like human identical milk oligosaccharide, synthetic HMO, artificial HMO, HMOs analog. There is no consensus so far. So my proposal is to use the term structures identical to HMO in breast milk. And why I think it's so important, because I think it's really important to differentiate HMOs which are naturally occurring in human milk, in human breast milk, and those which are biotechnologically produced, which are identical to HMO in breast milk. however, not originating from breast milk. And therefore, at least for the purposes of this presentation, I propose the term structures identical to HMO in breast milk. But as I said, there is no agreement, no consensus, and perhaps other people will come with better terms. I mentioned that these structures are obtained through biotechnological methods. So what are these methods? These are chemical synthesis, chemoenzymatic synthesis, but most recently, probably most often used, are microbial metabolic engineering, and E. coli is one of the bacteria which is being used. Probably not the only one which will be used, but this is probably the most used at the moment. Of course, one can say the isolation from human milk is possible. However, for the large quantities, it's not possible. So biotechnological methods are being used. Here on this slide, you see the examples of the first two structures identical identical to HMO, which are manufactured and approved by EFSA and FDA. And these were 2FL, 2-fucosyl-lactose, and LLNT, lacto-N-neotetraose. They are being added to infant formulas, and let me just now briefly talk about evidence from published randomized controlled trials on this infant formula supplemented with 2FL, with or without LLNT. And as you can see here, there are mainly studies in healthy infants, even if there is published study in children with cow's milk allergy. Intervention is usually infant formula supplemented with 1 or 2 of those structures identical to HMO in breast milk. And the outcomes, the primary outcomes, very often it's growth. And why it's growth? Let me talk about growth a little bit. Well, the general concept is that the infants receiving a new intervention should really show a similar pattern of growth to infants receiving an existing form of nutrition. An intervention is considered safe provided the average growth of study infants does not differ by more than half standard deviation compared to a reference or control group. And now let me show the result. There is evidence from both 2FL with or without LLNTs that there are infant formula supplemented with these structures identical to human milk oligosaccharides are safe, well tolerated, and support normal growth. And this is a result from the Pucha studies, which looks a combination of those two structures and show that weight, length, head circumference, BMI were very similar and in line with the WHO reference growth standards. So this was for infant formula supplemented with 2FL and with or without LLNT, which are safe and well tolerated and support normal growth. There are also studies on 2FL supplemented infant formula, which exhibit immune biomarkers similar to that of breastfed infants. Breastfed infants, you can see here, and these are two different formulas with two different levels of supplementations with 2FL. And various inflammatory immune responses were evaluated, and the specific signal of immune responses was similar to that of breastfed infant and 2FL formula-fed infants. There are also studies looking at infant formula supplemented with 2FL and LLNT when added to infant formulas, showing shift the gut microbiota closer to that of breastfed infants. And indeed, you can see that these infant formulas promoted bifidobacteria and reduced potentially pathogenic bacteria. And last but not least, the addition of 2FL and LLNT is associated with reduced morbidity and antibiotic use. In the next part of the presentation, I will talk about the secondary outcomes reported by parents. So caution is needed when interpreting the result, but the results are very important, and therefore I want to address them in more details. So these 2FL and LLNT added to infant formula resulted in lower incidence of bronchitis, reduced lower respiratory infection, reduce use of antibiotics, and reduce use of antipyretics, especially the reduced use of antibiotics. 31% is important. Not only in this study it has been shown, also in children with cow's milk allergy, published as abstract only as far as I know, but also show reduced use of antibiotics. Why it's so important? Because of the overprescription of antibiotics. Recent study from the United States, 70 children in the study involving more than 14,000 participants, 70% of them received at least one antibiotic prescription during the first 2 years of life. And there are data from other parts of the world showing that this overprescription is an important issue. So if this is the only effect of adding 2FL, LLNT to infant formula, it's really something that is worth considering. Evidence which I showed you from published RCT relates mainly to one or two structures identical to HMOs. However, we know that no single ingredient will act as a magic bullet. And as a matter of fact, after 2FL LLNT, a number of new structures identical to HMO became available, and they are listed on this slide. And not only that they are available, but this is published as of today only as an abstract, but will be presenting at the beginning of May and Pediatric Academic Societies Conference, which looks at the mix of this term infant formula supplemented with a mix of 5 human milk oligosaccharides, which are presented here. And the conclusion of this abstract is that infant formula supplemented with a diverse blend of 5 HMOs supports age-appropriate growth and soft stooling pattern, is safe again and well tolerated. And one can really expect that this mix of the 5 structures identical to HMO can have some really good health benefit, because if you look at the effects of individual structures, are very like this. But we need to have to wait for the full paper to know all the details. So further trials are needed, and as a matter of fact, they are underway. When I was preparing for this lecture, I looked at the clinical trials go, and there are 13 studies found for interventional studies evaluating human milk oligosaccharides in children. Various outcomes were studies. They do not add to 13 because some of the studies are looking at 2 or 3 outcomes at the same time. But you can see that people are working on it. By the way, not only in children, but also in adults. So my summary number 2 for this part of my presentation is currently available infant formula supplemented with 2FL with or without LLNT support normal growth, are safe and well tolerated. Further studies are needed, but functional benefits, please remember, reduced use of antibiotics, are very likely. Further studies are needed. It's very easy to say, but there are challenges in conducting infant nutrition studies. And in the final part of my presentation, let me focus on it. Current approach to test safety and efficacy of novel nutritional intervention, including the addition of the structures identical to HMO, is a pharmaceutical style approach. So RCT is accepted as a preferred approach. What is optimal? Optimal with breastfeeding should be as a gold standard. So randomization to breastfed and formula-fed groups. But this optimal is not possible because we know that infants cannot be ethically randomized to be breastfed or formula-fed. So what we do have, we have this randomized comparison of infant formula supplemented with any novel modification, like this structure identical to HMO compared to unsupplemented formula. And very often we have a reference group of breastfed infants who follow the same protocol as far as possible, but without randomization. But there are many challenges. Study protocols often require that infants to be exclusively formula-fed to be eligible for randomization. But exclusive formula feeding from birth is challenging, and also we do have problems with the timing of approaching mother without jeopardizing breastfeeding, because really breastfeeding, I will repeat again, is best. We also see increasing rates of mixed feeding, so recruitment of exclusively formula-fed infants is even more challenging. And many organizations like ESPEGAN, but also a group of experts, are addressing and developing standard for study. This is one of the most recent published in JAMA Pediatrics which tried to answer the question, what is the best way to ensure the validity of clinical trial of breast milk substitute while protecting trial participants? It's very much in line with the Cohort statement, but includes criteria specific for clinical trials of breast milk substitutes. Number of research, a number of themes were addressed. One of them was study design and breastfeeding support. I already touched it briefly, but there are two types of studies: non-inferiority of equivalence trials to demonstrate adequate infant growth and tolerance of a new breast milk substitute. And when it comes to approach to breastfeeding, participating infants should be fully breast milk substitute fed, and the decision not to use breast milk should be firmly established prior to enrollment to the trial. But there are many challenges, which I told you earlier. Both are intention to treat and pre-specified per protocol analysis is needed. There are also pragmatic superiority trials to generate data to support the nutrition of health claim. Some infants are receiving breast milk at enrollment, but it's important to demonstrate adequate support for breastfeeding, and ITT analysis is needed. Another part of the document is on trial intervention, but I will just add one additional issue here. Zinc ingredient, I already mentioned it. No zinc ingredient will act as a magic bullet. So usually a combination of various, which makes, of course, difficult to identify which of those is responsible. If it's a mixture of many, which one of them is responsible for the positive effect. Study outcomes. The primary and secondary study outcomes should be clearly established a priori, and statistical power calculation for the primary outcome should be based on a clinically meaningful effect size. And before a study is carried out, it's important to define what is an important difference between groups. It's important to define this minimal clinically important difference, which may be different for us as physicians and different for patients or their parents. But this is probably the most important thing when designing the study. This minimal clinically important difference defines the smallest amounts an outcome must change to be meaningful to patients or to parents. Regurgitation, think of regurgitation. What is important for us as physicians? One regurgitation per day makes a difference, or what is important for parents? They may be different. So minimally clinically important difference has to be established prior to the start of the study. And finally, study outcome. The endpoints used to measure each outcome should be valid, clinically relevant. The use of surrogate endpoints in place of clinical endpoints should be appropriately justified and interpreted. But there are some issues. There are very often differences in how outcomes are defined and measured, which make it difficult, sometimes impossible, to synthesize the results and apply them in a meaningful way. That's why it's important to have this core outcome set, which is an agreed standardized set of the most important core outcomes, which include both benefits and harm, which should be measured and reported as the minimum. Of course, other outcomes usually will be collected. And many groups, including some members of ESPGHAN, are working on this outcome set. But this is important because, and if you want to pull the data, for example, in the meta-analysis, the definition, the outcome should be really exactly the same and defined exactly the same. So my summary number 3 is conducting infant nutrition studies is challenging. However, high standards for studies need to be followed. I know that the audience are likely to remember only 3 things from presentation or speech. So let me summarize the 3 things to remember. First, specific HMOs found in breast milk may contribute to health outcomes later on, and establishing a link may lead to intervention strategies. And I showed you some of the link from human cohort studies. Currently available structures identical to HMO in breast milk when added to infant formulas are safe and well tolerated. Further studies are needed, but functional benefits are likely. Remember about this reduced use of antibiotic. If it's the only beneficial effect, it's really already an important finding. And finally, conducting infant nutrition studies is challenging. However, high standards need to be followed to trust the evidence. And I thank you very much for your attention.
Now we move on to the fourth speaker in this session. And it's my pleasure to introduce Professor Jean-Michel Haskell, who is the Professor of Pediatrics and the Director of the Division of Neonatology at the Maternité Régionale Universitaire in Nancy in France. Professor Haskell is the co-founder and coordinator of the French Board of Neonatology, corresponding member of the French Académie Nationale de Médecine, and an honorary member of the American Pediatric Society. He is author or co-author of about 170 peer-reviewed articles and currently the associate editor in neonatology at Frontiers in Pediatrics. Professor Haskell's research interests include breastfeeding, neonatal nutrition, developmental respiratory hemodynamics and pharmacology, neurodevelopmental outcome of prematurely born children, and public health in general. And today he will be talking about microbiota and HMOs in the preterm infant. Welcome, Dr. Haskell.
Dear colleague, we're going to address the topic on microbiota and human milk oligosaccharide in premature infants. Just to recall that in term-born infants, the total number of bacteria is about the same as the total number of human cells. In the gastrointestinal tract, there is a balance between beneficial bacteria, neutral type bacteria, and harmful bacteria, bifidobacteria being the most represented in term-born infants breastfeeded. But what about premature infants? Do we really know which bacteria will be the most representing in normal premature infants? Well, to address the question on microbiota and mobilities in Preemies, we studied the EPIPAGE-2 national cohort. This study was designed in 2011, and 68 French NICU were involved in that study. We evaluated 3,161 premature infants. The gestational age was 24 to 31 weeks. And within this cohort, 106 infants presented with severe necrotizing enterocolitis. The risk of enterocolitis were significantly associated with a slower rate of feeding and less breastfeeding. Within this cohort, we were able to study a subset of 94 cases where we measured microbiota. We confirmed that the microbiome was associated with NEC, especially Clostridium neonatale. On the graph, you may see in black the NEC cases, and in gray, the controls match on different propensity score. As you see, we observed a significant relationship between Clostridium neonatale and the occurrence of NEC in that population. There was also a high level of Staphylococcus, but it was also present in the controls. Of note, the infants who presented NEC did not have bifidobacterium in their gastrointestinal tract. To go further on that evaluation, we participated and designed the EpiFlow study. 577 infants from the EPIPAGE-2 with stool analysis at 1 month of age were followed up to 2 years postnatal age. In that population, we were able to group the infants into 6 clusters, knowing that one was not amplifiable because of low bacterial load. The clusters was defined by one predominant bacteria. As you may see, on cluster 1, it was Enterobacter, that was the most predominant bacteria. Cluster 2 was defined mostly with Clostridium. Cluster 3 by Escherichia coli and Shigella. Cluster 4 by Enterococcus. And finally, cluster 5 by Staphylococcus. When we looked at this cluster specifically, we wanted to evaluate whether gut microbiota was associated with NICU practices and 2 years outcome. We first recognized that cluster 4 and 5 with Enterococcus or Staphylococcus were significantly younger to start with than the one with Escherichia coli Shigella that was 26.8 weeks gestation versus 29.4 weeks gestation. Therefore, cluster 3 was taken as a reference. First, going to NICU practice, we observed that there was a significant relationship with the clusters and late onset sepsis occurrence. Cluster 1 cluster 2 and 3 had significantly a lower rate of low onset sepsis than cluster 1, 4, 5, and 6. Likewise, the study using skin to skin within the first week, the group showed that the cluster 3 had a significantly higher rate of infants with skin to skin within the first week than the other clusters. On the contrary, there was less breastfeeding in the cluster 1, 2, 4, 5, and 6, rather than Escherichia coli Shigella, which once again had a higher rate of breastfeeding. When we looked at the 2 years outcome, and we looked at death or morbidity, and morbidity was assessed by age and stage questionnaire, which is a developmental assessment validated in France, we observed again a significant relationship between the clusters and the outcome, as cluster 3, as you may see here, had 6% mortality and or morbidity, whereas cluster 1 and 2 had 3 times as much as Escherichia coli cluster, but this was not significant, but it was significant with Enterococcus, Staphylococcus, and no bacteria clusters. That means that gut microbiota in that evaluation and study was significantly associated with NICU practices and the 2 years outcome. Well, now we have been demonstrated some association between microbiota and human milk oligosaccharide. In this study from Corpella and colleague, they looked at the microbiota with regard to the route of delivery and the presence or not of oligosaccharide in human milk of the mothers. 4 groups were evaluated. The first one in red, infants born by cesarean section and no HMO in mother's milk. Group in orange, infants born with by cesarean section, but with fucosyl-lactose HMO in mother's milk. In dark blue, vaginal delivery without HMO in milk, and light blue, vaginal delivery with HMO in milk. As you may see, focusing on bifidobacterium, there was no significant difference between the infants with or without HMO in the milk who were born by vaginal delivery. On the contrary, the infants born by cesarean section had significant different microbiota with regard to the presence or not of HMO. As you may see in orange, 2-fucosyl-lactose HMO in mother's milk alleviated the effect of cesarean birth on infant gut microbiota. This was in term-born infants. Again, the association between microbiota, diversity, and HMO has been published. Here you may see in green, breastfed infant, in blue, infants fed with infant formula without HMO, and in red, HMO, 2-fucosyl-lactose and LLNT added to infant formula. As you may see here, 2-fucosyl-lactose and LLNT enriched infant formula shifts gut microbiota closer to breastfed infant. Now, we realize that HMO content in human milk may be very variable, and this has been related to maternal genetics, as mothers with secretion and secretor mothers has been observed, and non-secretor mothers on specific HMO. On the other hand, that was a genetic variation for HMO. In addition, this study by Austin demonstrated that within the first week of life, the level of 2-fucosyl-lactose was significantly lower in the milk of mother who delivered preterm versus the milk of mother who delivered at term. So one may raise the question that may HMO supplementation have a benefit on microbiota and beyond in Preemies? Clinical safety and efficacy data are required in order to address that question. This is why we designed an intervention study about the effect of a liquid supplement containing 2 HMO in preterm infants. The goal of this study was to demonstrate feeding tolerance among preterm infants measured by non-inferiority in days to reach full enteral feeding in the HMO group versus placebo. So the time to reach full enteral feeding would be an indication of adequate gastrointestinal tolerance and helps to provide sufficient nutrition to assure growth and impact the outcome. Secondary outcomes would be growth parameters, gastrointestinal symptoms, adverse events up to 12 months corrected age, fecal microbiota, gut maturation, and breast milk HMO composition in this mother who delivered prematurely. So this is the design of a study. That was a prospective randomized double-blind controlled trial in 27 to 33 weeks gestational age infants performed in 7 French centers. The product was administered as early as possible after 24 hours trophic feeding and always below 7 days postnatal age. Here you got the design. As when 24 hours of trophic feeding was possible, starting the product in what we call the pre-full enteral feeding period. The full enteral feeding was defined by both enteral feeding reaching at least a volume of 150 milligrams per kilo per day and parental nutrition discontinuation. Then the administration was pursued during all hospitalization up to discharge, and then the post-discharge follow-up will be performed. This product is colorless and odorless. It has an osmolarity of 260 milliosmol per kilogram and presented a concentration of 0.1 gram per milliliter. The ratio of 2-fucosylactose and LLNT is 10/1, and a dosing of 0.125 gram per kilogram given 3 times a day, reflecting breast milk composition. It is given before gavage or feeding when the infant becomes mature enough for sucking. So now the results. Here you have the baseline data for the HMO group in black and the placebo group in blue. There was no difference for gestational age, no difference between the group for very low birth weight infants and extremely low birth weight infants. The weight for age Z-score, length for age Z-score, head circumference C for age Z-score were not different. There is a slight difference in the rate of SGA infant, but that was not significant. Sex representation was even between the 2 groups. There was no difference for cesarean section, and the products were given at the postnatal age identical in the 2 groups. For the exposure to intervention and milk feeding, again, the HMO group in black and the placebo in blue, there was no difference in the pre-full enteral feeding period for the treatment duration in days. There was no difference for the rate of donor human milk, mother's own milk, or formula feeding between the 2 groups. During the full enteral feeding period, there was no significant duration that was not significantly different. There was a slight difference between the percentage of donor human milk and mother's own milk between the 2 groups, and the prevalence of formula feeding increased through full enteral feeding period, but was not different between the 2 groups. The primary tolerance outcome, that were the time to reach full enteral feeding, was achieved. As you can see here, the non-inferiority for the full analysis set or the per protocol data were achieved in both situations. We also looked at the adjusted mean time to reach full enteral feeding, and there was a 2 days difference in favor of the HMO group, but that was not significant. These are the results for growth and short-term outcome. There was no significant difference for weight for age Z-score, as you may see in red, the HMO group, and blue, the placebo group. As far as head circumference is concerned, there was no difference between almost all the 3 weeks of full enteral feeding, but there is a significant difference in favor of the HMO group at discharge. We had the same trajectory for length in these infants. Morbidity was not different between the 2 groups. We observed low average gastric residual, going from 0 to 3 milliliters per kilo per day. The mean stool frequency was around 3 to 4 stools per day. We observed 2 NEC in each group, 1 abdominal distension with diarrhea versus 4 in the placebo group. and 1 versus 2 adverse events causing product discontinuation, which was not different between the two groups. So in summary, the primary endpoint of tolerance, non-inferiority in time to reach full enteral feeding, was achieved in that study. There was a trend towards reduced time to achieve full enteral feeding in the HMO group. That was 2 days, but that was not significant. Weight gain was similar. Head circumference and length was slightly greater as discharge in the HMO group, which support the hypothesis whether HMO supplement support improved early postnatal growth. We observed comparable outcomes of gastrointestinal symptom and gastrointestinal adverse effects, leading to the conclusion that HMO supplementation is safe and well tolerated in premature infants. More to come. With still an ongoing analysis with this study, we're waiting for the results of fecal microbiota evaluation. We'll have results on gut maturation and immune biomarkers. We'll have the composition of milk, of HMO in milk, and we're waiting for clinical outcome and 1 and 2 years of age, knowing that most of the infants did not reach 2 years yet. So in conclusion, in premature infants, gut microbiota may show different patterns correlated with NICU practices and immaturity, and may be associated with morbidity and the outcome. 2, microbiota appears to be associated with HMOs in preemies, and HMO supplementation, when given as soon as possible after birth, is safe and well tolerated. It supports age-appropriate growth in weight, and it's consistent with length and head circumference improved early postnatal growth. I thank you for your attention, and I want to acknowledge here the other investigator of this study. Thanks a lot.